Hello, my name is Jeremy Roseberry and I work for Healthcare Education and Training. I am pleased to welcome you to today's training, HIV STD Skill Building course for disease intervention specialists in the state of Indiana. Your presenters for today are my colleagues from the Indiana State Department of Health's STD Prevention Program, and I'm honored to introduce Erin Egley, STD Specialist. I'm Olivia Ridgway, Operations Manager, Emily Fussell, STD Specialist, and Brandon Halleck, STD Specialist. We really hope that you find this training to be beneficial, and thank you so much for your time.
Hi, welcome to HIV Skill Building course for new DIS, and this course can also be utilized for seasoned DIS who might just need a refresher. So throughout this course, we are trying to develop competent, and successful HIV testers, connect testers to information, people, and resources that can provide support and improve Indiana's DIS risk reduction and reporting practices. DIS go through extensive training through passport modules about HIV, so we're just going to briefly go through HIV 101 with you. Remember, there are 3 different stages of HIV. You have acute, clinical, and AIDS stage. What's really the most important thing about this is HIV can be transmitted at any stage. There's a lot of myths out there about HIV transmission. Just remember, these are the 5 ways that HIV can be transmitted. We have blood, semen, that's including pre-ejaculate, vaginal fluids, rectal fluids, and breast milk. Common modes of transmission are sex, blood-to-blood contact, including injection drug use, mother-to-child, pregnancy, birth, and breastfeeding. Goals of testing for referral services, effective integrating of HIV prevention into the DIS's role, develop rapid testing procedures for DIS, client-focused risk reduction strategies that they can be utilized not just through HIV but also STD prevention, and provide accurate data collection and reporting methods. So preventing HIV is also preventing STDs. So there are common sexual transmission practices: using latex condoms while having sex, dental dams for oral sex, and using lube if none of those are available. Blood-to-blood transmission, avoiding blood-to-blood contact. Do not share needles or works. Works can be defined as cookers, water, cotton, etc. You know, they can use that. That can also help transmit HIV. Indiana has now approved syringe exchange programs throughout the state. If one is in your district, please become familiar where it is, the hours, locations, and your point of contact with them. So if you do have an injection drug user, you can refer them to those services. Another transmission is mother-to-child transmission. If a mother is taking her antiretroviral drugs, it can reduce the transmission from 20 to 2%. A mother must opt to have a C-section, and she is not allowed to breastfeed once the baby is born. Other methods of preventing HIV is PEP and PrEP. The medication has really evolved over this last decade. So there are drugs that can help people reduce the risks of HIV if they are having sex with a person who's already infected. If they can take 1 pill a day, it can reduce their risk sexually from 90 to 70%. There's also a drug called PEP. This is used for a person who's potentially been exposed, an exposure sexually, or a needle stick that they can take, and it's got to be taken within 72 hours of exposure to be effective. There's another campaign that's also out there as well. The CDC has developed a You versus You campaign that is basically saying that a person who is consistently taking their medicine and going to their doctor, they're actually going to suppress the virus so much it's going to be undetectable, so they won't be able to transmit to their partner. Now we are going to talk about outreach component, and that is basically when you're testing a person in the field, in the clinic. Okay, so when you're talking to a patient, this can also be used. This is an HIV tool acronym, but this also can be utilized into STD prevention as well. Just remember, public health, we love acronyms, so there's always so many of them. So we have CIGARS. So introducing yourself to the client, identifying the client's risk behaviors, identify our safety goals and behaviors, developing a client-focused action plan, and making referrals to provide support, and then summarizing and closing the session. HIV counseling is a client focus designed to support individuals from making behavior changes that will reduce the risk of acquiring HIV and also other STDs as well. Client focus means that it is a session tailored to their specific behaviors, circumstances, and their needs as an individual. Remember, there's not one size that fits all. Every client's a little bit different, so you don't want to have a standard counseling session. Everything's a little different. Remember, counseling is both verbal and nonverbal. You don't want to be all squiggly when you're talking to a patient. You want to be mindful of what you're doing and just stay focused on what the client's needs are. Remember, counseling is different than education. A good counselor does not always equal providing information. Counseling is not solving the client's problems, giving advice, or telling them what to do. Here's a quick guide to help build rapport with your clients during your session. You're going to set time restraints, match their body language, speak slowly and clearly, ask for your client's help, suspend your ego at the door, validate their opinions, ask open-ended questions, quid pro quo, show genuine appreciation, and manage their expectations. Open-ended questions is a learned skill that we all need to continue to practice as we develop and become a better DIS. Use implied imperatives. Give me, show me, explain to me, describe, tell me. That helps generate conversation. Ask who, what, when, why, how, and why, but just want to be cautious of exactly how you're asking that, because that can come off as judgmental as well. Use the silence approach. If the client is reluctant to tell you something and just doesn't want to speak, match their silence. Let them make the first move. And you just also want to avoid judgmental questions like did you, can you, do you know, those type of questions. Here's a list of just common closed-ended questions when it comes to HIV prevention versus open-ended questions. So we will all learn to rewrite our own questions, because we'll ask something and we'll see, oh, that was a closed-ended question. We need to reword it. How can I engage the client even more? So here is some examples of that. So if you have any questions, just kind of refer to that. So now we're going to talk about risk reduction and risk assessment. So how do we have people change their behavior? Think about a time where you started and stopped a certain behavior. Think about that when you're talking to your patients, because how challenging was it to start and stop a bad behavior? What were some of your bad behaviors? For me, I used to smoke, and so when I tried to quit, I had multiple stages in that. I really had to understand, like, oh, I had a problem, I need to address this, and then it was just building on those steps, and that's kind of what we're going to talk about. So some of you people might have learned about this in school. So the Transtheoretical Model, it's a model that is used, it's widely accepted. The model is illustrated to see different processes and change, okay? It also is shown that people are not ready to change and where they are in their changing, okay? So with me, I successfully quit smoking, but it wasn't overnight. It took me 3 years to really quit. So there's always different stages in change, and so I want you guys to watch this video and understand when you're seeing a patient that we need to understand where they are at in this model and try to nudge them further if they're ready.
This e-presentation will provide an introduction to the role of the Transtheoretical Model of behaviour change in relation to exercise. As a scientific community, we are often interested in the process that leads people to begin to engage in and then maintain healthy exercise behaviours. The Transtheoretical Model helps us to understand the different stages in this process, from not being ready to change, through to contemplation, i.e. thinking about change, and then maintenance, or persisting with the behaviour. As we go through the presentation together, we will explore the 5 different stages of change and relate each stage to a real-world example. Following this, you will be asked to reflect on different scenarios and explain how these might relate to different stages in the model. The Transtheoretical Model acknowledges that the stages of behaviour change are unlikely to be linear and more likely to be cyclical due to the fact that people often do not succeed in maintaining changes in their lifestyle. We like to think of this as a journey, and different roads can take you to different places, back to where you came from, or onto somewhere new. As we go through, we will discuss the 5 stages of the Transtheoretical Model. These are labelled as pre-contemplation, contemplation, preparation, action, and maintenance. When a person is at the stage of pre-contemplation, they are considered to be not ready. Individuals at this stage are unlikely to engage in the healthy behaviour in the near future, which could be up to around 6 months. At this point in time, individuals are really encouraged to think about the positives and negatives of their current behaviour and why engaging in more healthy behaviour could be adaptive for themselves and others. At this stage, a person might be down about their inability to change or be defensive when encouraged to adopt new behaviours. They are really not prepared to change their lifestyle. As an individual moves from pre-contemplation to contemplation, they are said to be getting ready. At the contemplation stage, a person has the intention to engage in the healthy behaviour within the next few months, but could remain in this stage for up to 2 years. People at this stage appreciate the positives of changing their behaviour. However, they may still try to avoid action and continue to put the behaviour off. At this point in time, others can help the individual by reducing the negatives associated with the behaviour change. Someone in the contemplation stage might have a thought about adopting a particular behaviour, maybe taking up a new sport or exercise, but are unlikely to act on that thought. At this point, the person is beginning to think about changing their behaviour. Following contemplation comes preparation. In the preparation stage, an individual is ready to engage in action within the next 30 days. At this stage, a person takes gradual steps that will help make the behaviour part of their everyday life. In this stage, it is possible that a person is doing a small amount of exercise but not quite enough to produce major benefits. An example might be to tell family and friends that they want to change their behaviour. At this stage, a key concern is regarding the individual's competence to do the behaviour and whether they are likely to fail. Being prepared and having a plan of action will help an individual to keep progressing. We might liken this to doing a warm-up before gradually easing ourselves into an activity. We are now at the point where action can be initiated. This is the 4th stage in the Transtheoretical Model, and it can often take some time to get to this point. People in the action phase have initiated behaviour change within the last few months and need to keep working hard to keep the healthy behaviour as part of their life. Strengthening a person's commitment to the behaviour will help to stop the person slipping back down through the stages. At this point, it is valuable to learn techniques that can improve commitment, such as acknowledging the steps they have taken and avoiding people who might encourage more unhealthy behaviour. At this stage, our runner is doing well, but could quite easily relapse and begin walking again because there's a lot going on. There are many different processes at play, and it is a challenge to maintain the healthy behaviour. The final stage in the Transtheoretical Model is maintenance. People who progress to the maintenance stage have changed their behaviour several months ago. These individuals are encouraged to share their experiences and seek support from other people who behave in healthy ways. At this point in the model, it is important to have an awareness of potential situations that might cause the individual to slip back into more unhealthy patterns of behaviour. For our runner, it is important to challenge themselves, but also to be able to overcome potential barriers. When facing a big obstacle such as a hill, the self-efficacy or competence to know that they can make it to the top will encourage them to continue with the behaviour. As we develop the Transtheoretical Model further, there are some key processes in operation that enable an individual to transfer between stages. One key factor in whether a person changes their behaviour and makes progress is decisional balance. This relates to whether the positives outweigh the negatives of doing the behaviour. A second process is self-efficacy. If a person feels competent and able to effectively change and adhere to the healthy behaviour, then they are more likely to do so. In addition, researchers have identified 10 processes of change which make progress more likely. This presentation served to provide you with an introduction to the Transtheoretical Model and by no means provides an in-depth discussion of all the key points for you. Your challenge now is to go away and learn more about the stages of change and be able to apply these scenarios into real-life examples.
There are 6 different stages here. You have your pre-contemplation, contemplation, decision or preparation, your action, maintenance, and relapse, okay? Just remember, anytime somebody's trying to make a behavioral change, relapse happens, okay? Relapse is part of recovery, all right? So you can use that for a person who is struggling, with sexual risk or a person who has substance abuse risk, okay? So just really understand, and when you're speaking to a patient, evaluate where they are in this stage so you can help move them along in this process if they're ready. So identifying risks. Risk behaviors that can be a result of HIV or STD transmission. So here's some common risk behaviors that we might encounter out in the field. So you have your injection drug use, your unprotected sex, your commercial sex work. Just think about what else is out in your community, what you are seeing, because in specific areas of the state, some people might have more injection drug use, other people might have more of commercial sex work. So just really understanding what the major risks are in your community and evaluate each person's risks. Our goal as a DIS is just to minimize the risks through action steps to achieve safer goals. Sexual transmission, these are a lot that we've talked about through Passport. So you have your common sexual practices, your penile, vaginal, anal, oral sex. You have insertive versus receptive, top or bottom for MSM. Recent condom use, sex partners. So you're looking at the number of sex partners they've had in a certain time period, their age, their gender, their HIV status, their STD status. Those are what we want to kind of find out about partners. Their recent sexual activity. Have they been exposed to any blood through sexual abuse, sex aids, toys, trauma? Those are areas that we want to ask too to help identify risks. The use of serosorting versus seropositioning. Serosorting is HIV positive people actively searching out other HIV positive people. They also use that on apps as well, where a person can also identify as HIV positive, so other HIV positive people will actually go out and try to search them. You also have seropositioning. Basically, that just becomes the type of sex they're having, top or bottom, versus an HIV negative person and an HIV positive person. Other risk assessment you want to do for substance abuse. Has a client ever had substance abuse or other issues? I mean, do they have an issue with alcohol, methamphetamines, marijuana, cocaine? You want to assess that when you're talking to a patient. Do they use drugs or alcohol before or during sex? Do they share drug equipment such as needles, syringes, cottons, cookers, or waters? And then you also want to, if a person identifies as an injection drug user, you really want to focus on who they're injecting with. Do they know there's those people's HIV or hepatitis C status, because the virus of both of those can actually live in the syringe for a longer period of time. If a syringe exchange program is available in your area, we would like you to refer those patients to them so they can get clean equipment to use, as well as different resources for their equipment. Remember, when you're doing risk assessment, there's also biomedical and biological factors that come into play. Is the patient's partner, are they on antiretroviral therapy, or is that patient taking PrEP? Has the patient had recent STD diagnosis, or have they been treated for an STD in the past? Are they using protection? What contraception use are they using? Are them and their partner actively trying to plan for pregnancy? So those are factors that can come into the risks as well. Why is risk reduction important? So we want to it's the focus on to help reduce the individual becoming infected if they're negative or transmitting HIV or STDs to other individuals. It's unreasonable to expect people to change their behavior and lifestyles overnight. So when you're coming up with these risk reduction plans or these action plans for your clients, you want to make reasonable and small goals for them to achieve. Okay, so reducing their number of partners from 5 to 4, using condoms from instead of 0%, how can we increase it to 10% of the time? Just making those small changes will help the client start to think a little bit more on like, how can I reduce my risk of getting this? And just remember, no one is perfect. We all make mistakes. We've all put ourselves in risky behaviors at some time or another. So we just want to help the people that are in front of us to help reduce their risk. It's really important to meet the client where they're at, okay? So preventing the spread of HIV and STDs. We need to set a realistic expectation and understand our clients. So why do people engage in risky behaviors? There's a laundry list of scenarios that could come out, but it's because patient might be stressed, they have lack of resources in their community, they have lack of education, they focus more on pleasure. So think about some other risky behaviors, why somebody might engage in that. That can help with resources that are provided. So how can we meet the clients where they're at instead of having them come to us? It's really important as a DIS to meet them where they're at emotionally and demographic. So if they're unable to make it to you as a DIS, we are able to go and meet them at their office. We can speak to them in a car, test them in a car, test them at their house, but we just want to be available for them so we can help reduce their risk of transmission. Safer goal behaviors are behaviors that a client is willing to support in order to prevent and reduce the spread of HIV and STD transmission. Based on their risk factors that you discuss, really just work together as a team to come up with a cohesive risk reduction plan, okay? What's really important about risk reduction plans and strategies is to assess the client's knowledge of STDs and HIV transmission. There's still a lot of myths out there, so you want to basically, let them know that these are the ways that these STDs and HIV is transmitted. Talk about if their partners are virally suppressed, how that reduces their risk, and also if they're on PrEP. And then really just correlate the STD and HIV transmission. So if a person is continuing to get diagnosed with a STD, they're at greater risk of transmitting HIV. Also, helping them actually talk to their partners about their HIV and STD status before engaging in sex. So if that's one thing that they're struggling, as a DIS, you can continue to help work with them through that process. And then also, based off everything else the client might tell you, you can provide them additional resources and support that is needed. So when it comes to risk reduction strategies for sexual transmission, we have abstinence. Abstinence is the only way to effectively prevent anything, but working with patients, that's maybe not always the best alternative. So what other ways can we use to prevent? So we have latex polyurethane condoms, male and female condoms, using female condoms with males as well for anal sex. Negotiating their partners for use, like you can work with your patient if that's a struggle that they have. Always remember to use them. Like, if they're saying, I always forget to have them, give them the tools that they need to always have them available. And also assess, do they actually know how to use them adequately? Use of dental dams and other barriers for oral sex to reduce risk of transmission. Lubrication, what you need to evaluate each of the clients and really work to see what risk reduction works for them. Some other strategies of sexual transmission is positioning for lowering your risk. Order from lowest to highest. So you have fellatio or blowjobs, insertive, receptive, insertive penile vaginal sex, receptive penile, the vaginal sex, insertive anal sex, receptive anal sex. Incorporating activities that bodily fluids are not exchanged. So you might have a mutual masturbation, digital penetration, using clean toys that doesn't cause anal or genital trauma, withdrawal before ejaculation. So just reducing your risk of sexual partners, risks of other STD infections, PEP and PrEP, those are sexual transmission. So another one, of course, we've talked about PEP and PrEP before. I wanted to give you this slide so you have additional resources. Really become familiar where PEP and PrEP are prescribed in your areas. So here's additional information on Truvada. So here's some risk reduction strategies for substance abuse. So, when you're talking to a patient, the benefit of abstaining or reducing their substance use, relationships between substance abuse and sexual risk practices. So meth use, because meth is really prevalent, at least here in Indianapolis, with men who have sex with men. Okay, so that puts them at a higher risk for HIV and STD transmission. Risks associated with injection drug practices. Benefits of substance use treatment, including relapse prevention, opiate programs. So some more about substance abuse risk reduction. If a person will continue to use drugs, how do we help them without contracting a virus? So reducing the number of partners that they have, using sterile equipment, not sharing other drug equipment like works, fluids, waters, cookers, cottons. Never to reuse equipment. If they're unable to acquire new drug equipment, how do they clean their syringes? And then how are they disposing? Because even when they dispose them out in the community, that's still putting other people at risk if they might be infected. So when you're talking to a client, you also want to develop action steps. So action steps are specific incremental steps that a client can take to help themselves adopt a safer goal behavior. So these are steps in between a client's currently does and where we'd like them to be. We never want to force somebody to accept change, so we have to evaluate where they are in their stages of change. If they're in that action stage and they want to make a change, how can we help them make those changes by giving them the appropriate resources, referrals to help them make those changes? And let's remember that when we're making an action plan for the client, we want to make small changes. We don't want to go from 0 to 100. How can we eventually get them there over time? So when you're creating a risk reduction plan for your patient, you want to give the patient multiple options for them to choose from. Give them a more buffet. We want the client to drive their risk reduction plan. As a DIS, we don't want to tell them how to reduce their risk. We want the patient to say, oh, I know I'm at risk. How do I reduce it? How can I physically? These are the things that I need to do to change. So you want to give them multiple options. But remember, if they're struggling, coming up with behavioral change ideas, you want to give them small steps, like how can you reduce your number of partners from 3 to 2? Or how can you increase your condom use from 5% to 10%? Make it small goals. You never want to go from, how can we go from 10 partners to 0 partners? You want to make it reasonable and actionable for the clients. Here is an example. So on the left-hand side, you had more of a global risk reduction, like using condoms, fewer partners, safer sex, and injection drugs. But on the right-hand side, these are more specific ways as a DIS to kind of give the client some ways to help reduce their risks. So many risk reduction efforts can be supplemented by giving the patient referrals to various community resources. As a DIS, it's going to be your responsibility to know where those resources are. And if there's new ones in your community, become familiar with them, reach out so you can develop that working relationship. So if a person is in need, you have a contact person for that, that agency. It's really important when you give a referral to a patient that I'm referring you to substance abuse, that you say, I'm going to refer you to substance abuse. When you go there, please ask for this person. Specific names really help the client instead of just giving them a more or less a passive referral by giving them a brochure or something like that. You want to actually give them, like, if you go here, please call, ask for this person, say that I referred them to you. That can go a longer way and possibly increase the likelihood of a patient actually going to seek out these services. So our goal as a DIS is to prevent transmission by arming them with as many tools as we can. So each session that we're with the patient, we're working with them to come up with a risk reduction plan, give them information and education about the viruses, HIV and STDs, and then give them resources that they need. If they're struggling using condoms, give them condom cases, or they need condoms, lube, whatever it might be, give them the things that we have that can help reduce their risk, offer those services to them. And then connecting them to other services and resources, and just anything else they might need. If they might need a person there when you're talking to them. They just might need that emotional support for somebody to listen to them about what's going on with their life. We want you guys to be accessible to the patients, or the clients, I'm sorry, and let them know that you're there. And so if they need you in the future, they can contact you about anything. So, but you just want to open up that lines of communication, let them know that you're here in your community and you're here to help them.
I'm going to be talking to you today about referrals and resources that are available for you as a DIS. I'll also be talking about delivering preliminary positive test results. As a DIS, you'll want to be sure that you're providing the best care to your clients, so it's really important that you know the resources that are available in your area. As you're talking with clients, you want to actively listen to their needs and assess what resources and referrals will be best for them. If you're unsure what resources are available in your area, you'll want to get with your local supervisor or community leaders to ensure that you have proper documentation to follow up with them. A resource that is available to you is care coordination. This is a specialized form of case management available to those living with HIV to provide a variety of health and social services. All HIV positive patients should be referred to care coordination. The goal of care coordination is to ensure continuity of care, promote self-sufficiency, and also enhance quality of life for those living with HIV. It's important to note that HIV is eligible to those patients who are HIV positive and also an Indiana resident. There's no time restriction for the length of service, and clients can terminate the service at any point in time. Additionally, clients can also receive care coordination outside of the county that they live or region of residency. Another service available to you is HIV Medical Services, and this is a program that assists clients who need therapeutic medication and also medical services. It gives clients full access to comprehensive health insurance at no cost to them, and it also provides both short-term and long-term benefit packages. Another resource available to you as DIS that you'll become very familiar with is partner services. During the initial HIV testing, you'll want to perform a preliminary interview to elicit partners. This is just done to be sure that you can get partner information from the client at that point in case they don't come back for the confirmatory result testing or you're unable to get a hold of them after this initial interview. Partner services is completely voluntary, but we do encourage the clients to participate. And it's also important to stress confidentiality. DIS are held to the same standard as providers to protect a patient's confidentiality, and partner services is also ongoing. Other resources available to you other than the ones mentioned previously, you want to be sure that you are assessing the client as a whole. So even if a client has a non-reactive test result, we want to be sure that we're providing referrals that will benefit them. This could include their basic needs for food pantry, clothing, housing assistance, medical services, other STD testing that they might need, social services, and any substance abuse treatment that might be needed as well. Next, I'll be talking to you about delivering preliminary test results. There's a sequence of events that will happen, and these can be interchanged depending on what the client needs at this point or the type of test that you're using. You'll first want to ensure that you're introducing yourself and explaining to the client how the session will go. You'll then want to provide and perform the rapid HIV test. As that test is getting going, you can fill out the HIV form, and then you can continue to assess the risk behaviors and safer behaviors as well. Lastly, you'll want to discuss the risk reduction plan with the client and be sure that this is client-centered and also really realistic for the client. Once the test is complete, you'll want to report those test results and then complete any necessary follow-up that could be needed, additional referrals, or that additional confirmatory testing. Then lastly, you'll want to summarize and close out the session. When you're delivering the test result, it can be tough, but it's important to know that when you're delivering these results, you have to keep in mind the magnitude of the news that you're delivering, and as time goes on, you'll get more and more comfortable with delivering those results. When you're delivering the results, you want to be sure that you're providing them clearly and simply. You want to explain what the result means at the client level, so making sure that you're meeting them where they are in understanding these results. And then lastly, you want to let the client react and respond to their immediate needs. This could mean being silent, answering any of those immediate questions that they have, or being supportive in some other way. You want to be sure not to overload them with too much information at this point. You want to be sure to emphasize the need for a confirmatory result and not give them false hope. You want to then assess how the client is coping, so you want to be sure to ask them how they're feeling and ask what questions they have. Lastly, you want to advise them to take precautions to avoid transmission to others while waiting for those confirmatory results. So you have a rapid test result, what's next? There's several steps that as a DIS you'll need to take. First, as soon as the patient is emotionally ready, you want to be sure that you collect that confirmatory test. Then you'll want to schedule an appointment for the patient to come back for those results. HIV positive tests must always be given in person. If you're a DIS testing the client, you can invite a local care coordinator to come to this appointment where you're delivering the results to ensure that warm handoff. If you're giving the results at another local agency, you can be sure to work with that local agency to ensure that you can bring a care coordinator or bring any additional resources as needed. Delivering a non-reactive test result, you want to be sure that you're providing the result clearly and simply. And you'll also want to be sure that you're explaining that result in simple terms, so meeting the client in their way of understanding. Delivering a non-reactive test result, you want to be sure that you're covering that window period. So when you're testing the client for that rapid test, that only goes back to the exposure that occurred at least 3 months prior to that test. After that, you'll want to assess the client's reaction to the test result and respond to any immediate needs that they might need. Lastly, you'll want to encourage future testing and provide any relevant routine testing such as STD testing as well, or provide them additional resources. How not to give a result. You want to be sure that you're not being judgmental when you're discussing their behaviors or providing the test result itself. So you don't want to go in and say, I have good news for you. Your test result came back non-reactive. You want to be sure that you're providing a non-judgmental tone when speaking to the client at all levels. Lastly, when you're closing out a session, although these sessions can be fairly brief, you want to be sure that you're providing a summary of what was occurred during that session. So check in with the client emotionally to see how they're doing, go over what the results mean again, and then also emphasize confidentiality. You can answer any questions or concerns that they have that might not have come up before. Lastly, discuss the risk reduction plan that you came up with, and then give any necessary materials or resources needed, and be sure that you give them your card for phone number that they can contact you should they need it later. Next, you'll view a video that talks about delivering test results in the field.
even though this person knew, was pretty much sure that their test result was going to be positive, I still had to go back into that room, look them in the eye, and tell them, you have HIV.
That's a hell of a thing to have somebody tell you that you have the virus or that you have AIDS.
That is something huge and life-changing for a patient to have to hear that news and for you to have to deliver that news.
My greatest fear was leaving my kids. I'm sorry.
We're dealing with human beings, and we're dealing with the possibility of giving them a result that's going to change their life.
As HIV testing is increasingly integrated into a wide variety of healthcare and community settings, more providers face the difficult task of delivering what is often life-changing news. This video will offer you strategies and approaches for stating and explaining HIV rapid test results, responding effectively and compassionately to the client's immediate reactions, assessing the client's support network, and providing effective referrals. You will hear from clients who have received HIV test results and from providers who have given them. You will also view 3 scenarios which demonstrate approaches for delivering HIV rapid test results, both reactive and non-reactive.
She came in the room, and she told me that I should sit down, and she put her hands on my shoulders. She said, "Chris, I got bad news for you." And I seen the look on her face. It was as if she had got bad news. And she tried to console me before she even gave me the news. And then she told me that I had HIV, and it seemed like she was ready to bust out and crying, but she tried to keep it professional, and she did it very well. She handled it very well. Through my experience, I've had a lot of discrimination against me because of my HIV status. I mean, you would think by now that people would have a better understanding about this disease, but the stigmas are still there. They look at us as dirty people. I know I'm not a dirty person. I'm a good father, and I try to portray that every day. I try to set good examples for my daughter. I think the message should really get out there that people should really, know more about this disease before they start discriminating against us just because we're sick. That's all it is that we're sick.
My name is Lori. I was diagnosed in 1991 with full-blown AIDS. I was 5 months pregnant, 64 pounds. They said my baby was fine, but I would have to be on medication probably for the rest of my life, which I am. It's a hard thing to go through. I would say to providers, just to be there for the people who have HIV or AIDS. Don't look down on them. Don't be scared of them. Treat them like they're a normal human being, because we're normal human beings. But you can also be cautious without making it so known to them. It's a terrible thing when you have a disease and healthcare providers don't even want to be bothered with you. It's really a hurtful thing. It really is. When these people told me that I had the virus right after they all just scattered and went their own way, I just wish I would have had somebody to comfort me when they told me. It broke my soul. It did. I felt like they could have taken me alone, one-on-one, put your arm around me and tell me, take me into a room. Would you like a cup of coffee? Would you like some juice? You want a donut? Or let's take a walk even. Come on, let's go outside. It's a nice day. Let's take a walk. Be a friend, you know? Care.
I noticed my husband was looking ill. He was losing weight. I didn't want to accept that it was possibly AIDS. That's what made me go get the test. My sister was with me. They called us into a room, and it was just this lady sitting behind a desk with the folder. And in an inadvertent way, she told me that my results were positive because as soon as she said the words, "Would you like a psychiatrist or a psychologist to be here?" I already knew what the end result was. I knew that I was positive. And then she was sort of like very robotic about it. I guess she was just, like just doing her job. People fail to realize that when you get a disease like this, it affects your friends, it affects your family, it affects your whole circle of people that surround you on a daily basis. So it's devastating. Put yourself in that person's shoes. How would you feel? A person needs compassion at that time. And a little more kindness from the person. Don't be so cold about it. Because remember, this is devastating news that you're going to give to someone.
My first experience in giving positive results was very scary. Bringing that patient back, it just felt like a long walk for me, even though it was a very short one. And to bring that patient in and just have to tell them, it was very hard. The patient kind of just looked at me and started crying. There was no screaming or "you're wrong" or walking out or anything like that. So I just immediately started crying as well and allowed him to have the moment that he needed. I took him upstairs to get him some water. We talked about resources, contacts, people that he could talk to. And I felt as though that he walked out feeling the best that he could for that moment.
It can be nerve-wracking in the beginning because every person that comes in is a potential positive. I've had to deliver a few positive results now, and none of them have been easy. And the first one was difficult. The person was already showing symptoms. He had a partner for 7 years that was HIV positive. He was coming yearly to get tested, and it so happens that this was the year that he was going to be, he was going to get his positive result. I must admit that he took it better than I did. I tried my best to remain calm and to keep everything, but I knew that my ears, for example, I couldn't keep them from turning red, no matter how much of a poker face I was trying to hold. There was emotions going through me.
Giving results has become easier for me. I actually have a conversation with them now beforehand, asking them, if this result comes out positive, what is that going to be like for you? How do you think you're going to react? Are you coming in here? Have you done previous tests? Is this another one of the tests? Are you trying to confirm it? I can come back in, be a little bit more confident, be a little bit more helpful in terms of getting them referrals or just talking with them about it instead of being this nervous wreck.
When we have someone with really, really high risk, there's a million things going through my mind. How am I going to reduce this person's risk so that they don't give somebody HIV if they are positive? Or how am I going to reduce this person's risk so that they won't catch HIV? How am I going to comfort this person if I have to deliver a positive result? Some people say that they don't take them personally. We're going to take them personally. This is the type of job it is. We're dealing with human beings, and we're dealing with the possibility of giving them a result that's going to change their life.
You will now view 3 scenarios illustrating interactions between providers and clients as HIV rapid test results are delivered. These scenarios are only examples. They demonstrate some good approaches for giving rapid test results, both reactive and non-reactive, but they are not meant to show all possible strategies. When delivering HIV test results, healthcare providers must tailor their approach by listening and responding to the client's specific needs. "22-year-old Antonio has come in today specifically for an HIV test. While waiting for the test result, he has told the counselor, Eric, that he has had multiple sex partners and regularly uses club drugs.
Hey, Antonio, the test is finished. The result is negative, which means that you are most likely not infected with HIV.
Negative? Wow, are you sure?
It's great news, huh?
You know, I really did think it was going to be bad. So I'm okay, huh?
Here's what the negative results tell you. At this time, you're not showing signs of HIV infection. But there is something important for you to know. For the particular HIV rapid test that we use today, if you were exposed to HIV any time within the last 3 months, this test might not pick that up.
Well, it's still good news, right? I mean, I don't have it.
Antonio, you've been really open to me about everything that's going on in your life, the partying and all. Have you been in any situations in the last 3 months that would put you at risk for HIV?
Yeah. Well, I can come back for another test in 3 months. And then I'll be okay, right?
I sure hope so. Antonio, it would be great if you got another negative result.
You got that right.
And if you want to get another negative result and make sure that it means that you're not infected with HIV, then you want to make sure that you're protecting yourself. So, how can you do that?
Well, I guess I could try those things we've been talking about. Using a condom every time. And take it easy with the drugs.
So I'll see you again in another 3 months. Here's some condoms that you can take with you. In the meantime, if you want to talk about any of this some more, call me.
Hey, brother, thanks. Really, thanks.
Here are some tips and approaches for delivering a non-reactive, negative HIV rapid test result. Present the test result clearly and simply and explain the meaning of a negative test result. Discuss the seroconversion period, the window period, with the client and the possible need to return for another test.
We always have to assess what their risk levels are. Is this the appropriate time for them to be having their test? Are they within the window period? Do they need to come back? Are they using condoms effectively? So we always have those conversations.
Recognize that while many clients will be relieved to receive a negative test result, some will have mixed feelings, including guilt and anxiety. Use this teachable moment to reinforce messages and plans for reducing HIV risk.
If they're coming in and they've had inconsistent condom use or they've had a lot of partners in the past year, any sort of high-risk behavior, the test comes back negative, and it's almost a situation where you look them in the eye, okay, you know that nervous feeling you had, your palms were sweating, you know, shortness of breath, you're freaking out because you think this is going to come back positive. You're lucky. It didn't. It came back negative, and you know, you've had this high-risk behavior in your past. You can do different things in your future so you don't have to be in this position again.
I have a negative result in front of me and there's a lot of high risk. The important thing for me is to educate the client on lowering that risk. Whether you call it harm reduction or risk reduction, the thing is to lower it. So then we start talking about what's comfortable for that client. Condoms is, of course, the #1 protection that we're going to have in the situation.
You know, this is a good time to make condoms sexy, to talk about different lubricants and glow-in-the-dark condoms or whatever it may be, that you're going to try to make the condom seem like it's the greatest sex there ever was. Now, again, you can't really lie to them and say how fantastic it is, but at the same time, you want to put the risk level, if it's high, along with how hard they need to work in order to not contract HIV. You want to make it the same and not just use condoms and I'll see you later. More of a, listen, there's other condoms out there at easy stores that are in the local area that you can go to, and the sex will be fantastic, and at the same time, you'll remain safe.
Be supportive, encouraging, and non-judgmental.
Whatever personal biases you have to check them at the door. And you have to make sure that they stay outside of the door. Whether it's a bias that you may have against prostitution, it might be a bias you may have a bit against homosexuality. You are not there to judge whatsoever. You're there to provide results, and you're there to assess the risk that the person is taking at the time and see if you can lower that risk.
Keith has come to the STD clinic because of symptoms and has agreed to be tested for HIV along with testing for other STDs. Keith has disclosed to the provider, Carolyn, that he has had sex with both women and men in the past and has been going to a Narcotics Anonymous group for the past year.
Okay, let's get this over with. What's it show?
Keith, the rapid test result is positive. But we won't know for sure if you're infected with HIV until we get the results from a confirmatory test.
I knew it. This time, I knew it. Okay, look, I'm gonna get going. I'll be okay. All
Keith,
right?
can you wait just a few minutes? I just gave you a really difficult piece of news. It sounds like you were expecting this result.
Yeah. No. I don't know. I guess I knew it could happen. I messed around. I mean, what I think was going to happen. Look, miss, I know all about HIV. I don't think there's anything I don't know. I just screwed up.
I know this is not easy to think about or talk about, but what's the first thing on your mind right now?
Look, I know you mean well.
Keith, you don't have to talk to me. Of course you don't, but there's some information I'd like to give to you. Now, if I bring up something you don't want to talk about or ask a question you don't want to answer, it's okay.
You asked me what I'm thinking. I'm thinking HIV caught up with me and I'm going to be sick. If I want to live, I'm probably going to have to take those medications and I'll still be sick. And how I'll ever pay for that, I have no idea.
You're right. Some people who take the medications do have a hard time with them, but many people don't. And you may not even need medications right away.
What do you want me to do?
As a first step, we need to get the results from the confirmatory test. And then I can connect you with Dr. Lyman, a specialist in HIV treatment, who can see how you're doing and work with you to find the best way to fight the virus and keep you healthy. Now, if she decides that you do need to be on medications, the clinic there has a social worker who can help you get set up in a program that will help to pay for HIV medications. Now, I know these people. They provide excellent treatment, and they really care.
Uh-huh.
Keith, you told me that you recently started a recovery program. Was it Narcotics Anonymous you mentioned?
Yeah, for all the good that's going to do me.
You know there are NA programs around town specifically for people with HIV.
Yeah? Well, maybe one of these days I'll check it out, but not right now.
Okay, well, What will you do when you leave here today?
I don't know. Maybe I'll call my sponsor.
And how do you think your sponsor will react to your news?
He's handled everything else I've handed him. He's cool. He's there for me.
If you'd like to call before you leave here, I can find a private space for you to do that. Otherwise, please just know that you can call me back at any time. If you have any questions at all or just need to talk, here's my number. I'll be here.
Here are some tips and approaches that providers have found helpful when delivering reactive, preliminary positive HIV rapid test results. State the test result clearly and simply, and emphasize the importance of the confirmatory test. Be prepared for a full range of client reactions. Some will cry, some will shrug, some will storm, and some will be ready to bolt.
Anybody, I think, that is getting news like that, or that are waiting for a test results of an AIDS test, you're gonna be anxious, you know. And when she told me that that it came back positive, I was just like, even though I knew in the back of my mind, I knew what he had, and I knew that I was at risk because I was with a person that was ill. I was devastated.
There are many patients who will have a variety of reactions. They might look one way or talk to you one way, and you have no idea how they're going to react when you do give them a positive result.
One of the things that we learned in training was have an envelope with you. So if that person wants to bolt and get out of there, at least you've given them the resources to take. They may not take them, and that you don't think that you haven't done your job, because maybe they just need to get out of there. Most patients come back or they call and ask for you.
Really know your referral network. Have referral information at your fingertips, both referrals for HIV medical care and for other services such as substance abuse treatment and financial assistance.
What I would tell providers is to know their referral sources and know somebody at least in there by first name, and sort of drive around the places where you're going to be sending them. Walk in there, find out whether or not it's crowded, find out whether or not it's empty, there's nobody there, and why there's nobody there. Some programs look great on paper, and some programs don't look great on paper, but you go there and, oh my goodness, all the stuff that's out there.
It's very important to have a support system. Without one, I really don't know where I would be. I might have stopped using drugs, but I could have gone back. I could have ended up getting worse with the virus by doing that. Just to have a whole support system, whatever it is that you're dealing with, the virus, drugs, whatever it is, sex, you have to have those support systems. If I didn't have it, I probably wouldn't be here. I really wouldn't. I don't think I would.
Ask the client what he or she will do after leaving the clinic. Work with the client to make a short-term plan to get support and to take next steps.
Some people do have a person that they can talk to, and some do not. We kind of try to flesh out who would be the first person that you would want to tell to help you support you through this time. It doesn't have to be right away, but we always encourage them to have someone they can trust that can help them through the situation.
Close the session, but not the door. Let the client know that he or she can call you or come back with any questions or concerns. Nicole is a young mother of 2 children, ages 6 and 3. In discussing her medical history with the nurse practitioner, Angela, she has revealed no risk factors for HIV infection. She has come in today for a checkup and Pap test and has agreed to a rapid HIV test, which is offered routinely at the Community Health Center.
Nicole, I have the results from your test. Your rapid HIV test is preliminary positive. That means that you most likely are infected with the HIV virus. Now, we don't know...
What? What did you just say? Wait. Are you telling me I got the virus? Are you telling me I got HIV? Listen, we got to do this test again. This has got to be a mistake.
We do have to do another test to confirm the results. At the same time, I don't want to mislead you. This test is very accurate, and it's most likely that the confirmatory result will be positive.
But wait. No. What does this mean? I mean, I got kids.
I know.
Oh God, what does this mean about my kids?
Listen, I want to answer all your questions, okay? Any questions that you have. Will you let me do that? Okay, you're asking about your kids. What is concerning you most about your kids right now?
If I got it, do they? If I got it, what's going to happen to them?
Listen, I know most mothers like you get so worried when they hear the results that they want to have the children tested, and I can help you do that if you want.
Yeah. Okay. But what'll happen to them if I get sick and die?
Listen to me. I want you to listen to me. You can live with this. People are living a really long time with HIV now, as long as you follow the doctor's advice, as long as you take proper care of yourself. You can be here for your children. I have several patients myself that have HIV. I can help take care of you too.
But how could this happen to me? What do I do now?
Listen, I know that you're probably feeling extremely overwhelmed, and this news is hard to hear, but let's focus on things. Let's take one step at a time. Let's get you hooked up with the right care that you need today. I'll call the lab, set up the confirmatory test, and when we're finished here, we'll do that, if that's okay with you. Who else knew that you were coming in today for a checkup?
My mom. She has the baby, and she can get my son from the bus. Oh, my mom, this is going to kill her.
She loves you a lot.
Uh-huh. And I put her through a lot.
It is really important that you have someone you can talk to about this. And if your mom can handle the news, then that's great. But you may want to wait to tell her until the test results come back and you're sure, because once you tell someone, you can't untell them. Do you have someone in your life that can be supportive now?
I don't know. I just don't know.
Okay, Nicole, we have a counselor here right now that can talk to you and support you through this. And if you'd like, I'll take you down to her right now.
Okay.
Here are some tips and approaches that providers have found helpful when delivering reactive, preliminary positive HIV rapid test results. State the test result clearly and simply, and emphasize the importance of the confirmatory test. Let the client express emotions. Listen and stay engaged. Compassionate listening is a powerful response.
You know, you deal with a lot of people that have health issues, and you know, a little compassion would go a long way.
I think that we are all so used to saying, I want to give them the results, I want to give them all the referrals, I want to give them this information, and that's satisfying and gratifying as a professional, but on the humanistic side of it, you have to allow that person to process that information, especially since it's life-changing.
Help the client to understand that HIV is not a death sentence. With appropriate medical care, it is a treatable, manageable chronic illness.
Today, HIV is not a death sentence anymore. It's important that even in a negative and in a positive result, that you remind and you educate the client on what HIV is today as compared to what it was 25 years ago. So today, as testers, we also have to be educators within our session, within the counseling and testing session, to remind the client that there are medications that they can take today that can give them a normal lifespan, and if they follow their doctor's advice, which is basically a healthy lifestyle, and making sure that you go in and you see the doctor every 3 months and you keep your appointments, that you can actually live a normal life.
I'm healthy now, and that's because I take the medication as directed, I have a healthy diet, and I exercise every day. I take very good care of my body.
Explore who the client is able to confide in and rely on for support. Be ready to refer the client to a counselor or mental health care provider if indicated.
Most of the people that go there, are going there by themselves, unless, of course, their significant other is bringing them there or something. So they don't want nobody to know that they're there. So when you ask them the question, do you have a support system, they didn't think about that. So they start thinking, oh my goodness, who am I going to tell? That's usually when I say, is your mom around, your dad around? The closest family, brothers, sisters, maybe you have a cousin, a best friend that you've had for a while. But it's somebody that really could keep your status confidential. You can't be somebody that likes to kind of run that, and we all have people like that in our family, so that you have to get them to start thinking who is the best person to kind of share this with, because this person is actually going to be holding something for you also.
I had a lot of support from my husband. I had a lot of support for him. I went to meetings. You have to keep people within your reach. So if you do need them, they're there. You can't just let yourself go with nobody to talk to. You have to have that kind of access.
As you have seen, delivering HIV test results can be emotionally charged and difficult work. But it is also an opportunity to provide real help to a person in need. You cannot change the outcome of the test, but how you deliver HIV test results and referrals can make a world of difference to the client.
I don't want to see that client walk down with their head hanging down to the floor. I want them to walk out of my office and have some type of hope, even if it's a positive, because there is hope.
Going in there, of course you're going to have to deliver bad news. It's never easy. But not being afraid to give them a hug or just hold their hand or tell them, it's not the end of the world. We can figure out what you need to do next so that you may live a long and happy, healthy life.
I've come to the realization that even though I may never see this person again, and there's a really good chance of that, they're always going to remember me, whether it's my name or whether it's my face, but that is a life-changing moment.
Me being that person delivering the news, I don't want them to think that has changed my view on who they are. And I'm kind of a touchy-feely person, meaning that I'll if they need a hug, I'll give them a hug, a handshake. I do that with just anybody. So I just want to make them know that that hasn't changed my view, and that's probably not going to change the view of the people who care and love them.
Think of that person as if they were your family member. Maybe your daughter, your son. That's all. Be nice. It's a good thing.
Hi, Erin. So you're coming in today for a PrEP referral, right?
Yeah.
I just wanted to introduce myself. My name's Emily. I'm a disease intervention specialist here at the health department. And what that essentially means is that I'm here to help test you for STDs, help educate you about STDs, provide information for the PrEP referral, and let you know where I can send you out to for that. And we're also just going to go over some of your risks and make sure that I can help you out today as best as possible. I do just want to let you know that everything we talk about today is confidential. And what that means is that I can't share this information with anybody without your permission, including any spouses, any partners, parents, sisters, friends, what have you. Everything we discuss will stay between us unless you let me know something, for instance, if you're causing harm to yourself or others, that I may have to share this information with other people. Before we begin today, did you have any questions or concerns that I could address for you?
No, not really.
Okay, we're going to go over what your intake form and what information you provided for me today. So I just want to confirm that you live in Bloomington at 5555 Main Street?
That's correct.
Okay, and what number is good to contact you at?
410-555-5551.
Okay, great, thank you. And can you just verify your date of birth for me?
3470.
Okay, wonderful. And I see here you don't have any occupation listed. Can you tell me where you work? Or what do you do for work, or how do you get your income?
So I work at the local library.
Okay. And what do you do at that library?
I reshelve books.
Okay. And who do you live with at home?
Just myself.
Okay. And I just have some additional questions for you here on the form. Have you had any previous STD history before, such as any chlamydia, gonorrhea, or syphilis infections?
No.
Okay, great. And then what kind of medicational allergies do you have, if any?
I don't have any allergies.
Okay. Okay. And we will just jump right into it. So I know you're here today for a PrEP referral. Part of the PrEP process is that we need to get you screened for STDs, including HIV. So I know we're going to do the HIV test today. Are you interested in getting screening for chlamydia and gonorrhea as well? It's a very quick process. I'll just have you leave a urine sample, and then we'll discuss your risk, and if you need additional testing, I can't offer that to you. Does that sound good?
We could try. I went bathroom before I came in, but...
Okay, if necessary, I can give you some water and we can hold that till the end of the test and we can get that done. So we're just going to jump straight into it. Before we get the HIV test administered, I do just want to go over this information sheet with you. This is an information sheet about the HIV test I'm going to administer. What this essentially says, Erin, is that you are at least 13 years old as of today, that you understand I'm going to test you for HIV, and that you understand if this result comes back positive, I'm going to draw your blood for a confirmatory test and send that to a lab to confirm that preliminary positive from the rapid test. And if it does come back positive, we're going to counsel you on some things, and I'm going to offer you assistance into care coordination and getting into treatment and things like that. Does all of that make sense to you so far?
Yeah.
Okay, great. If you would, just fill out this form you're going to print, write your address, and then sign for me. Awesome, thank you so much, and I'm just going to sign this. All right, Erin, so now what we're going to do, because the rapid test that I use today is instant, we're going to go over your risk assessment first so I can make sure that I'm helping you the best way possible. I'm going to ask you some questions about your sex life and about any drug habits you may have. I'm not here to judge you. I don't care what you do. I'm just here to help you and make sure that we can get you into the care that you need. If anything makes you uncomfortable, please let me know and we can readjust. And again, I just want to ensure you that everything we talk about today is confidential, okay?
Okay.
So we're going to verify some of your information again. Can you just verify that year of birth for me?
3470.
And you live in the state of Indiana? Yes. Okay. And what county do you live in?
Monroe.
Okay. And what's your zip code?
47401.
And do you identify as Hispanic or Latino?
No.
Okay. What race do you identify as?
White.
And what sex were you assigned at birth?
Male.
And what gender do you currently identify as?
Male.
Okay, great. So again, this next part is just going to assess your risk, and also we're going to talk about PrEP. So I'm assuming you have heard about PrEP before, correct?
Yeah, that's why
Okay.
I came in.
Absolutely. And are you currently taking PrEP, or have you ever taken PrEP?
No.
Okay. And now we're going to talk about your sex partners. When was the last time you had sex with a male in the past 1 year?
The last time, maybe a month ago.
Okay. When was the last time you had sex with a female in the past 1 year?
Did not.
Okay. When was the last time you had sex with a transgender partner in the last 1 year?
Never.
And when in the past 1 year have you ever injected drugs or other substances?
I've never injected a drug.
Okay. What other recreational drugs do you use?
I smoke occasionally.
And what do you smoke?
Marijuana.
Okay. And how often would you say you smoke?
Daily.
Daily? Okay. And what other drugs are you using besides marijuana? Do you use any drugs during sex, such as methamphetamines or poppers or nitrates or anything like that?
I don't use any of those none of those anyway.
Okay. And when in the past 1 year have you had sex with somebody who is HIV positive to your knowledge?
Never to my knowledge.
Okay. And when in the past 1 year have you had anal or vaginal sex with somebody without a condom?
A month ago.
Okay. And how often would you say you have sex without a condom with your partners?
Pretty regularly.
Okay.
It's just kind of, I really have one on hand or...
I understand that. And we can discuss a few ways we can help you develop some more risk reduction plans here in a moment. To your knowledge, have you ever had sex with somebody who injects drugs?
No.
And then that's a no question. Okay, so let's talk about your risk. What risk do you perceive yourself to have? So what do you think you're doing that's putting yourself at risk currently for contracting STDs or HIV?
Well, everyone always talks about condoms.
Condoms are an important or important part of risk reduction. Do you think that's something, or do you feel like that's something that you can incorporate into your daily life?
Possibly.
Okay, what can we do to see if condoms would work for you? I can provide you some for free. Would that help?
I don't know.
You don't know? Okay. What are your concerns about condom usage?
Access, they're not that comfortable.
Okay, I understand that.
The brands you guys hand out aren't always.
I know the brands that we hand out can sometimes not be the best, but the good news is that we do have some name brands here at the health department. So if using a name brand condom, if you feel like that would help you increase your condom usage in the future with your partners, we can definitely take care of that for you today. What other concerns do you have about condom usage?
Having one on hand.
Okay. What do you think would help you keep some on hand during your sexual activities? Where do you typically have sex?
At home.
At your house. So what about keeping condoms on the bedside, keeping them near the door, keep them in your underwear drawer if you're concerned about privacy?
Yeah, that could work, I guess.
Okay. So condom use could be a potential thing we could increase and help reduce your risk. What other risks do you think you are currently having?
I don't think I'm that risky, really.
Okay, so let's talk more about your sex partners. So you have male sex partners. How do you meet those partners?
Either on, with an app, or maybe if I've gone out and having a drink.
Sure. What apps are you using currently?
Grindr.
Okay. And when was the last time you had sex with a partner from Grindr?
A month ago.
About a month ago. And when was the last time you met a partner at a bar? Or wherever you go out to have a drink?
What is it, October? So, summer sometime.
Summer, okay. So what can we do to maybe reduce your app usage, or what steps can we take to maybe limit meeting those partners off the apps or in the bars?
I don't know. I want to meet somebody, so I pull up my app.
I understand that. So using apps online is an easy way for you to get to know partners and to meet people in your area, correct? Yeah. Okay, so here's some steps that maybe might help you in the future. I totally understand in 2018 that meeting people online is one of the easiest ways to get to know people. It's the quickest way to get to know people, and that's totally fine. What we definitely want to do is we want to protect ourselves. So before you engage in sexual activity with somebody you meet from an app or a bar, you could always bring them into the health department. You guys can get tested together. We do offer our screening at a low to no cost for people. So if somebody doesn't have insurance or they're having financial troubles, we can reduce the cost of that test for them. So we can make it financially feasible for them to come in and get tested. What do you think about that? How do you feel about that?
I I mean, it seems like a good idea. I at least get myself tested, I guess.
So that's another thing too, especially if you want to start PrEP, like I was saying, routine screening is a part of PrEP referrals. So once you get on PrEP, you're going to be under the care of an infectious disease doctor, and they're going to want to get you screened every 3 months. So frequent screening is another risk reduction method that we could implement for you that would help you reduce your risk of acquiring chlamydia, gonorrhea, syphilis, or HIV. So you can get screened every 3 months with PrEP. Some people like to get every 6 months. Some people like to get screened once a year, depending on how frequently and how many partners they're having sex with. So with PrEP, we can definitely get you screened every 3 months. And then if you ever do find a steady partner, you can always bring them into the health department and we can take care of them here. Or if your partner is also interested in getting on PrEP, the infectious disease doctor would be more than happy to take your partner on as a client as well, and we can get them started on PrEP and get them started on routine care. What kind of questions do you have so far for me, or what kind of concerns do you have at this point?
I don't have any real concerns.
Okay, so let's jump back to, I know we're kind of bouncing all over the place a little bit here, but let's talk about PrEP for a moment. I just want to make sure that you understand it. So what do you know about PrEP? Tell me what you know.
Well, I know it's a drug that I can take that stops me from getting HIV. And that I have to talk to someone to get it first.
Correct. So fortunately, the process to get on PrEP is fairly easy now. Here locally, we do have a new PrEP clinic that started under the infectious disease doctor at the hospital, when I can write you a referral to that clinic. It happens on every Wednesday. A nurse practitioner runs that clinic. And what will happen, Erin, is you'll go in there, you'll come in with your referral, the nurse practitioner will get you all intaked. You'll get all your screening today here with me, so we can send you with those test results. And then the nurse practitioner will offer you some education, do a little bit more screening with you, to make sure that this is the right decision for you, and then it's fairly simple to get started. Do you have health insurance?
Yeah.
Okay, great. So your health insurance can cover the cost of PrEP. If you're ever in a position where you lose your health insurance, you can pay out of pocket for PrEP at the clinic. They do take cash payments. The manufacturer of PrEP also does offer some discounts too. We can find those online. Okay. So those are available if you're ever in a position where it becomes financially unfeasible for you. Definitely give me a call and we can make sure that we get you stayed on PrEP, okay?
Okay, great.
Okay. Okay, Erin, so I just have a couple more questions for you about your partners before we administer the test today. So you are having sex with male partners. What type of sex do you have with your male partners? Oral sex?
Yeah.
Okay. And when you have oral sex, do you give or receive oral sex?
Both.
Both, okay. And do you have anal sex with your male partners?
Sometimes.
Okay. And when you have anal sex with your male partners, are you top, bottom, or versatile?
Versatile.
Okay. Okay. Thank you for that information. I asked this information because it's important in regards to STDs. Chlamydia and gonorrhea can be site-specific, so I asked these questions so I can make sure I'm going to offer you the right testing. Have you received anal sex within the last 60 days?
Yes.
Okay, so if you're interested, when we do your chlamydia gonorrhea screening, I can't offer you an anal swab. It is self-collected, so it'll be a personal thing that you do. I can explain to you how to collect that. But this way we can make sure that you don't have any STDs that are in your rectum that we're not going to catch. Is that okay?
Okay.
Okay, so now we're just going to administer the HIV test. This is called the Insti test. It's a rapid test, which means we will have a result within 30 seconds. The way this test works, Erin, it's very simple. It has a little gel thing here. This is where we're going to put your blood sample into, and we'll just get it set up here and I'll explain it to you as I do it. And the way this Insti test works is in 3 steps. So I'm going to prick your finger. We just use a lancet, so it's not going to be a huge stick. We're going to siphon some blood out of your finger. I see you're a little nervous about that stick.
I'll be all right.
You'll be all right. I promise the lancet is not too big, and it'll just be a very tiny finger prick, and as long as you bleed good for me, it'll be very quick, okay? If at any time if you feel nauseous or ill during the blood draw, just let me know, but like I said, this will go fairly quickly. And what this test is doing, Erin, is it's looking for HIV antibodies, so it's not looking for the virus itself, but we're looking for evidence that your body has tried to fight HIV infection. This test is going to detect any exposures that you've had before the previous 3 months. So that's an important distinction that I want to make to you, is that if you think you've had a recent exposure within 3 months, I would encourage you to come back and see me, so that way we can make sure we catch any infection in the early early stages. Before I test you, I do just want to go over a few things. So the possibility that this test may be positive can occur. What type of concerns do you have about the test coming back positive?
I mean, I don't want it to be positive.
Absolutely. Do you feel like you would have a good support system at home if you did have a positive result today?
Well, my mom's pretty supportive.
Okay.
But I'm just going to focus on it being negative. But
Absolutely. I don't want to frighten you or scare you, but it is something I do like to talk about with my patients so that way we're prepared for all options. So I just want to reassure you that if the test is positive today, what's going to happen is we're going to draw your blood and I'll give you more information about the further steps that happen after that. We can get you hooked into care and we can get you the treatment that you need. HIV is an extremely manageable disease in 2018. It's no longer a death sentence and the treatment is very effective and it will make sure that you're well taken care of, okay? All right, so this will be fairly quick. Like I said, this test is instant. We're just gonna do this little finger prick. Okay, and then can you give me a finger from your non-dominant hand? Okay, I'm gonna have you fold up your fingers. We're gonna use your middle finger. And like I said, if you at all start feeling lightheaded or nauseous, please just let me know. Most people do fine with this, but I just want to make sure that if you start feeling sick, just holler, okay? Like I said, this will be a very small poke. Okay, 1, 2, 3. See, that wasn't so bad. Okay, give me just a second. We're gonna siphon up some blood here. Okay. Put some pressure on that. I'll give you a Band-Aid if you need it. And what I'm doing now, Erin, is I'm putting your blood sample into some chemicals from the kit. This is going to bind with any antibodies that may be present, and this test, like I said, will give us a result within 30 seconds, okay?
Okay.
Okay, Erin, so your test result is back, and as you can see here on the INSTI test, you have 1 blue dot, which means you are non-reactive today. And what that means, Erin, is that this test does not detect HIV antibodies as of today, but as I said, if you believe you've had a recent exposure, you definitely want to come back and see me within the next 3 months so we can make sure that you're okay. Do you have any questions or concerns about your result today?
And you're saying that's negative?
Yes, sir. So the 1 blue dot on the INSTI test indicates that it did not detect any HIV antibodies, so we can safely assume that you do not have HIV infection as of today.
Okay. Awesome.
Okay, great. So just to summarize our session today, we are going to get you referred to PrEP. I do have a referral ready for you to the infectious disease doctor at the clinic. You can call them on your own time and make the appointment with the nurse practitioner, and then she'll get you intaked on that. And then before you leave today, we're going to have you submit a urine sample for your chlamydia gonorrhea screening. I'm going to draw your blood for a syphilis screen, and I'm also going to walk you through the process for your anal swab for chlamydia and gonorrhea as well, okay?
All right.
Okay. Okay, Erin, so your INSTI test result has come back, and as you can see here, the 2 blue dots on this INSTI screen indicate a preliminary positive result for HIV today, okay? And what this indicates is that this test has detected HIV antibodies, and what's gonna happen after this, Erin, is I'm gonna draw your blood for a confirmatory test. I'm gonna send that to my state laboratory so that we can confirm this result. I can see you're a little anxious right now. What kind of questions or thoughts or feelings are you having?
You said it could be a false positive, right?
So that is a possibility. However, these tests are 99% accurate. The rapid tests are very good at detecting active infection, but that's why we do a confirmatory test. That secondary test is going to let us know for sure whether or not the HIV result is true. However, like I mentioned, this test is 99% accurate, so we can safely assume today that you are most likely infected with HIV.
I don't know what to say.
I understand. I know this can be a really hard situation and a lot of information to take in at once. What kind of concerns or feelings are you having?
I mean, you know, I didn't really think I was putting myself at that much risk, you know. I at least talked about it.
Mm-hmm. It can be confusing, and realizing certain things that we may have done put us at risk for this disease. But as I mentioned previously in our conversation, this disease is very manageable. Fortunately, in 2018, we have very wonderful, awesome treatments available for HIV. The most important thing that's going to happen from this point forward, Erin, is that you need to be an advocate for yourself, and you need to be very, how do I want to say it, dedicated to taking care of yourself. So the most important thing you can do for yourself while we're waiting on your confirmatory test result is you're going to avoid sexual contact with other people. I know you said you don't use drugs, but we want to make sure that you're not having any blood-to-blood contact or needle sharing with other people, and we just want to make sure that we don't want to spread this infection to other people. We're also going to, I can give you some information if you're ready for it about care coordination. It's a program that I can help you get linked into. You already have health insurance, which is a big half of the battle, so that's going to alleviate a lot of stress for you, because your health insurance will be able to get you right into care and get you right on treatment. What happens after this, Erin, is once I get that confirmatory test result, you're going to come back in and see me. We're going to sit down, we're going to discuss the confirmatory test result, and then we will go from there. And what happens after that is we contact the care coordination. They can make the appointment for you to the infectious disease doctor. The infectious disease doctor is going to run another series of tests to see what type of HIV you have, what the strain is, and what medications it best responds to. And then after that, your HIV doctor is going to be your primary point of contact for your infection and managing it. Care coordination will definitely help you adjust to the new routine, because it will be a new routine. You may have to make some lifestyle changes, so if you're using any drugs, you may want to cease using drugs. It'll just help your immune system be healthier. You may want to make some lifestyle changes in terms of eating, in terms of drinking, and things like that. The healthier you can keep yourself, the easier it's going to be to manage the infection. Okay, I can tell you're a little anxious right now. Is there anything on your mind that you want to share, or anything I can address for you?
I don't even know where to begin.
I know, this situation can be extreme, and it can be life-changing, and it can be a lot to process. And that's why I wanted to ask you earlier about, do you feel like you have good support at home? If you don't feel like you can share this information with your family, with your friends, with your partners, that's fine. Your HIV status is your information to share. The only people you are legally required to share that with is people you want to have sex with, or people you want to share injection drugs with. You just need to notify those people of your status, and you need to make sure that you give them a chance to opt out of having sex with you or sharing drugs with you. But your information is private, so you don't have to tell anybody until you're ready. I do have some resources I can give you. In case you get home and you start feeling really down, or if you start having suicidal thoughts, there is a wonderful organization called Mental Health of America. They're a great organization. You can call them in the meantime, and they can get you connected to any type of mental health that you may need. If you need some crisis support, they can connect you to crisis support. They can also get you connected to support groups locally in your area, so you can connect with people who are also positive, so you don't feel so alone. Because I know this infection can make people feel very isolated and feel very alone, but I do want you to know that there is support out there. There are people who will care about you and still love you, even if you are actually positive, okay? And then if you're interested in it, I do just want to go ahead and give you this brochure too. This is for the care coordination. This is for Aspire. This is what is locally available to you. As I said, care coordination is a program that is absolutely free to you should your status be positive. You can enroll in this or disenroll in this at any time that you please. But I highly recommend you stick with this program, because they're going to help you adjust to this new routine. They can, if you ever fall into an area of your life where you don't have a job or where your finances struggle, this program can help you get into housing. They can help you afford your bills. They can help you provide food. They can also help you afford your medication should for whatever reason your insurance stop paying on it, or you lose your insurance, or you just can't afford the out-of-pocket costs for it. Like I said, this is your personal choice, but it would be a great resource for you in the beginning. Okay, so here's what's going to happen, Erin. So now that we have your preliminary positive rapid result, we are going to draw your blood for a confirmatory test. I'm also going to draw your blood for a syphilis screen, and we're going to conduct your chlamydia and gonorrhea screening as well. And after we do that, if you need to sit and just kind of breathe and relax for a moment, that's fine. I'm here to answer any questions or concerns that you have. Okay. Okay, Erin, before you leave today, I just want to go ahead and set an appointment. Do you think you have some time next week to come in and see me for your test result?
Yeah, Fridays usually.
Fridays? Okay, Friday at what time would work best for you?
Maybe 3 o'clock.
Okay, we can set your appointment for 3 o'clock. So what I want you to do in the meantime, definitely rely on these resources. So if you begin to have feelings that you're uncomfortable with, or if you have questions or concerns about the rapid test or your potential diagnosis, you can always call me. Definitely rely on the mental health resources in case you need them. Another thing I want you to do is I want you to start thinking about your sex partners that you've had within the last 1 year. And what I can do for you, Erin, is that I can anonymously call and notify these partners of their potential exposure. I legally cannot disclose your name to these partners, no matter how much they ask me, or if they say, I'm not going to tell you until you tell me. I cannot tell these partners how I got their information. What I usually tell partners is that their name was given to me by somebody who cared about them and wanted them to have the opportunity to get tested and treated. It's up to that partner whether or not they want to accept my services, but I can have that hard conversation for you. That way you don't have to approach these people and potentially damage any type of relationships you may have with these individuals. So just keep that running list in your mind. What I'll need is their name, a phone number, or if you talk to them online, a screen name would be useful. And as I said, I can't tell these people your information, so I just want to, again, assure you that everything we discuss is confidential, including your partners. Okay? Do you have any questions about that process? Or any questions about your follow-up appointment?
No, I should be able to make it.
Okay.
Thank you very much.
You're welcome. I'll see you next Friday.
See you next Friday.
Now we're going to look at forms that are necessary during a patient's confirmatory results appointment. The first form that we'll need to fill out is the test result and release of information form. The forms here on the PowerPoint are just an example. You may have different forms at your agency. This form is used to designate who has permission to receive the test results and other medical information about the patient. You'll want to be sure that you fill these out with the patient so you can share the patient's STD or HIV information with their physician. The other form that you also need is the duty to warn form. In the state of Indiana, we have a newly positive patient fill this form out, and this form states that the patient must inform their current or previous sex partners or needle-sharing partners of their status. This ensures that the current sex or needle-sharing partners have an opportunity to opt out of the activity with the newly diagnosed patient. This form must be completed with the patient when you're delivering their positive test results. Information on the duty to warn form is also on the HIV information sheet that you have the patient fill out prior to administering a rapid HIV test. The next form, this form is called the partner notification form. This form is only usually filled out by an HIV counseling tester or another tester who is not trained in partner services, as DIS have a process for partner elicitation. This form will typically be faxed to the DIS from the HIV testing site, and you will receive separate forms for every partner that a newly diagnosed patient may have. The next form that you'll need is the CTR short form case report form. This can be found online at the ISTH STD HIV website, and we use this form when we are reporting confirmed positive test results. You'll want to complete this form with as much detail as possible, and you can utilize the back page for extra notes if you need to. You'll want to mail this form to ISTH within 72 hours of the scheduled delivery appointment in the select envelopes that will be provided to you by ISTH. There is currently no other forms of submission available for reporting a positive HIV diagnosis. If you do not have these forms at your agency, you can always contact your specialist and they can supply you with these. This is an example of the short form, and there's also a long form that's available online as well. However, that long form is typically only filled out by clinicians. Again, you will mail this form in once you have diagnosed a patient in your clinic in the select envelopes provided to you by ISDH. This graph here shows us how many different types of tests we have for HIV. We have NATs, CIAs, multi-spots, and Western blots. This graph also shows us how many days after exposure these tests can become positive. This test looks for HIV RNA, antibodies, or P24 antigens. On this next slide we can see that we have several different types of HIV tests, and what this graph is showing us is how many days before a Western blot becomes positive if these other tests become positive. Most often as a DIS or an HIV counseling tester, you will do rapid HIV testing. Rapid HIV testing is a process that detects HIV antibodies present in the body that are due to HIV infection. Most often you will get same-day results. They will either be instant or they will be within 20 minutes. Rapid HIV testing is important because it is easy and has a very high reliability, up to 99% accuracy or greater. Results can be provided almost immediately, and clients who have a non-reactive result do not have to follow up or come back for their results. However, if you have a patient who has a preliminary positive, they will need additional follow-up. It can be used in a wide variety of settings, such as in the client's home, in the clinic, or in the field. Rapid testing is often conducted with whole blood finger sticks or with oral fluid samples. At ISDH Labs, we use two different types of tests for the confirmatories. We use the CMIA, or chemiluminescent microparticle immunoassay, which detects HIV-1 and HIV-2 antibodies, as well as the P24 antigen. There's also the Genius HIV test, which we use to differentiate between HIV-1 and HIV-2 antibodies. This also targets the HIV-1 and HIV-2 peptides. These are the tests that ISDH Labs will run for your confirmatory testing. There's also different types of tests for HIV. For HIV screening, we use the CMIA. If that is reactive, the multi-spot will be conducted. For a confirmatory, we use the CMIA again and the Genius test as mentioned in the previous slide. For oral fluid samples, or the OraSure, we use the Western blot to test those for confirmatory samples. And now we're going to discuss different types of scenarios that can happen once you submit a blood sample for a confirmatory test. After a preliminary positive rapid test, you will send your confirmatory sample to the ISDH lab or another lab, whatever you use. And what's going to happen is they're going to test the sample for HIV-1 or HIV-2 antibodies. If this is positive, we give this result as a positive. If this result is negative, the specimen is sent out for additional NAT testing. These are typically sent to a reference lab, so the results may take a little bit longer to get back. If that NAT is positive, this indicates a very new infection, and the result is given to the patient as positive. If the NAT is negative, the result is given as negative, meaning the rapid preliminary positive was potentially a false positive. Additional information on NAT testing, it is performed in the following scenarios. So you may have samples that screen reactive, but they're multi-spot negative, samples that are multi-spot indeterminate for HIV-1, or samples that are multi-spot HIV positive, but cannot be differentiated between HIV-1 or HIV-2 antibodies. NAT testing will be performed at a reference lab, and you may also see NAT listed as NAAT or NAT. You may also see another type of confirmatory test called an OraSure, which was previously mentioned. These tests are becoming obsolete, but it is important to know how to handle these tests should you come across them. They are 99% accurate. They do only test for HIV-1. They do not screen for HIV-2. The cotton pad is placed between the patient's cheek and gum and held for 2 to 5 minutes, and then you place the results, you send the results to your lab, and you'll have those ready within 1 to 2 weeks. An OraSure oral fluid sample is tested by a Western blot. Some more information about OraSure. You always want to check your expiration date. You need to explain the testing procedure to the patient since it's dependent on their actions. You also need to ask your patient if they have had anything to eat, drink, or if they've smoked anything, or if they brushed their teeth within 10 minutes of administering the test. If the patient says yes to any of this, you should wait an additional 10 minutes to ensure that a false positive does not occur. You'll have the client hold the swab in their cheek for 2 to 5 minutes. You'll put the swab into the specimen vial. You'll break off the top portion of the swab, replace the cap, and then you'll package it appropriately and send it to the state lab for it to be tested. What we have here is a graph of result reporting language. So as a DIS, you need to be familiar with how HIV lab results are reported so that you can interpret them appropriately. We won't go over this entire list. This is here for your reference. But for example, if you have a screening test that's reactive, your multi-spot shows that the patient is HIV-1 positive. The reporting language from the lab is going to say HIV-1 antibodies were confirmed. What this means is that you can report this result to your providers or to your patient that they are in fact positive for HIV. And it's important to be aware of this reporting language as you may receive some HIV labs from providers, but ISDH HIV surveillance will always confirm these positive lab results for you. The next slide that we have here is just the result interpretation. So we would never use the medical jargon in the previous slide with the patient, and the way you're going to explain the results to the patient is in very simple terms. So again, for example, if you have a screening result that is reactive and our multi-spot is HIV-1 positive, you would report that to the client or the patient that they are HIV-1 positive. And we just want to define what HIV-1 and HIV-2 are. So here in America, HIV-1 is the most common and globally the most common strain of HIV. HIV-2 virus is endemic in West African countries. Both strains are acquired through sexual fluids, blood, or breast milk. HIV-2 typically progresses more slowly than HIV-1. The primary genetic difference is that the VPU gene in HIV-1 is replaced by the VPX gene in HIV-2. And now we're going to talk about how you collect the specimen and how you ship it to ISDH labs, or alternatively, if you do not use ISDH labs, how you could ship it to your reference lab. So for specimen collection, you are going to use standard NCCLS practices for venipuncture. You'll want to collect at least 7 to 10 milliliters of blood. If you cannot collect this much, the lab may reject the sample due to insufficient value. You will want to use serum separator tubes or SSTs whenever possible. And if you have a centrifuge at your agency, it's highly beneficial to go ahead and spin the whole blood sample down into serum. Serum is preferred for transportation, storage, and for testing. However, ISDH labs will accept whole blood samples. They are capable of spinning down a sample if you do not have a centrifuge at your agency. You should store your specimens at a refrigerated temperature of 2 to 8 degrees Celsius. You should ship these as quickly as possible to minimize antibody deterioration. Be cognizant of the weather, as frozen whole blood samples cannot be used for testing. What you see on the PowerPoint here are just examples of different blood tubes that you may have at your agency. The serum separator tube on the left is called a tiger top. The red tube in the middle does not have the gel separator, and then there's gold tops on the right that does have the gel separator. You always want to label these tubes with 2 patient identifiers, the patient's name, first and last, plus an identifier of date of birth, or using your OpScan or DOC number. Another important thing to remember is that you always need to label these in the patient's presence. There are transit time limits. Specimens arriving beyond designated transit times will be rejected due to specimen degradation. Again, as I mentioned in the previous slide, you need to be cognizant of the weather and make sure that if you're shipping during the winter, you'll want to see if you can have serum, but if you have whole blood, take precautions so that the whole blood does not hemolyze during transit. This is to comply with the manner in which the FDA has approved the testing kits. Testing samples outside of the time frame could result in false positives. This is a letter from ISDH that details what the time frame is for sending HIV specimens. We have a time frame of 7 days. Day 1 is the date of the draw. When you're drawing specimens and shipping specimens, you need to be cognizant of weekends and state holidays, as this may delay the shipping time. Also, we need to be aware of when the lab staff is available and what their staffing is like. The results may be delayed due to staffing or state holidays. Common causes of sample rejection is hemolysis, which is the rupture of the red blood cells into the serum. Mismatch of patient name and ID, so the name or the OpScan number on the specimen tube need to match the submission form exactly, and if they don't, unfortunately, the lab may reject the sample. There is a lack of patient identifiers on the specimen tube, so you may have left a specimen tube blank on accident, or you may not have added the last name or forgot a birth date or an OpScan number, or the specimen may have an excessive amount of fat in the serum, which we call lipemia, or the specimen tube itself is leaking or broken. What we have right here is the examples of the ISDH shipping containers that are provided from the labs. So in this shipping container that you will send your HIV confirmatory blood sample in, there are 3 components. There's the blood tube, which is not provided by ISDH, but it is provided by your agency. We have the watertight secondary container, which does have absorbent material on the inside. And then there's the rigid outer container that has the appropriate biological hazard label attached to it. You should attach your paperwork from LIMSNet around the secondary tube, and then place the secondary tube inside the rigid container, and the blood tube should be nestled inside the secondary container against the absorbent material. This is the blood tube. This is the secondary container with the absorbent material. We're going to place the blood tube inside the secondary container. You're going to seal that up. Then you're going to take your LIMSNet paperwork and wrap that around the outside of the secondary container and place that into your appropriately labeled rigid cardboard container, and that's it. Packaging all specimens as Category B in accordance with the biological substance federal guidelines is extremely important. We want to be able to appropriately identify these substances as they travel through the mail. ISDH Laboratories does provide you with these containers and the appropriate mailing labels. If you do not have these available, you can always call to order containers at 317-921-5875, or alternatively, you can send an email to containers@isdh.in.gov and send a request with your mailing address and how many tubes you need. Alternatively, if you do not have the ISDH laboratory specimen packages, you can alternatively package your specimens. So you must follow the biological substance category B guidelines, and you can use other packaging. So you can place a specimen in a leak-proof biohazard bag, put your LIMSNet in the pocket of that biohazard bag, and avoid placing the LIMSNet paper against the specimen because we want to protect the paper from contamination, and we want to protect our lab techs from contamination as well. You'll want to place the biohazard bag with the specimen into a rigid outer packaging such as a cardboard box, and you'll want to ship this with cold packs whenever possible to preserve the sample. The best option for shipping your specimens to the ISDH laboratory is using UPS, that is ISDH Lab's preferred method of shipment, or if you're participating in the ISDH chlamydia gonorrhea screening program, you can send your HIV confirmatory blood samples through campus ship as well. You'll want to avoid the United States Postal Service, as they have a tendency to lose packages and or leave our specimens in unfavorable environmental conditions, which can degrade our specimens and cause them to be rejected at the lab. You should be shipping your specimens to arrive at ISDH Monday through Friday, and you'll want to be cognizant of state holidays as nobody will be there to receive the specimen. So this is how you submit your specimens to the state laboratory. You'll use a website called LIMSNet. LIMSNet is an electronic specimen submission system that allows submitters to submit testing requests electronically rather than with paper forms. DIS will use this website to submit not only their HIV blood test results, but they can use it to submit chlamydia, gonorrhea, syphilis, and hepatitis results as well. The LIMSNet link is on the PowerPoint, and there's also a training manual on the main page at the very bottom that you can go through for further instructions and guidance on how to access LIMSNet. If you do not already have a LIMSNet account, you can call the ISDH LIMSNet help desk at the number listed here, or you can send them an email as well. They are available Monday through Friday from 8:15 to 4:45 p.m.
And now we're going to talk about rapid HIV tests. Indiana State Department of Health currently recognizes 3 different HIV rapid tests. The first is the INSTI, the next is the Alere, and finally we have the OraQuick. In these following videos, each will demonstrate how these HIV rapid tests are run. The first video is for the INSTI HIV rapid test. The next video will be for the Alere rapid test. And finally, we have the OraQuick HIV rapid test.
The INSTI HIV-1 HIV-2 antibody test is the world's fastest, producing results in as little as 60 seconds. The test procedure is simple, and the test kit contains all the components required for testing. Before using the test, read package insert to familiarize yourself with INSTI and become familiar with universal precautions. INSTI is intended to be used in a step-by-step manner with no pauses or breaks during the testing process. First, open the INSTI package and remove all contents from the pouch. All 3 INSTI reagent solutions are color-coded and numbered for easy identification. Tear open the membrane unit pouch at the pre-cut edge and carefully remove the membrane unit without touching the center well. Place the membrane unit on a level surface. Make sure the tab of the membrane unit is orientated towards you. For sample identification purposes, the tab of the membrane unit may be labeled with the patient's name or identifier. INSTI can be used with fingerstick blood, venous whole blood, serum specimens, and plasma specimens. First, open bottle number 1, the sample diluent, and retain the cap. Do not open bottles 2 and 3 at this time. Position the patient's hand in a way that is comfortable for the patient and allows you to easily press his or her finger to collect blood. The hand should be positioned at waist level or lower. Wipe the fingertip with the provided alcohol swab. Massage the patient's finger in one motion towards the tip to allow the blood to move to the surface. The fingertip will become slightly pink. As soon as the finger is dry, twist and remove the protective tab from the lancet. The appropriate areas to prick the fingers are indicated by the areas marked yes. Hold the finger firmly below where the lancet will be applied. With the other hand, position the lancet. Holding the lancet by the body, press firmly to fire. Release the patient's finger and immediately dispose the used lancet into a proper sharps container. Do not squeeze blood from the finger until you have the pipette ready in hand for collection. Lightly squeeze the finger in one motion towards the tip to release a bead of blood. With INSTI, the first drop of blood does not need to be wiped. Hold the pipette horizontally and carefully touch the tip of the pipette to the bead of blood. Capillary action will automatically draw the blood to the black fill line. Do not squeeze the bulb of the pipette. Hold horizontally and gently, being mindful not to cover the pin-sized hole on the 50 microliter fill line. Add the 50 microliters of blood from the pipette to bottle number 1, the sample diluent, by squeezing the pipette bulb. The pipette stem has a pin-sized hole located at the black line. Squeezing the pipette bulb usually expels the blood from the pipette stem. However, if squeezing the bulb does not expel the blood sample into bottle number 1, cover the pinhole with gloved fingers and squeeze the bulb again. This should release the sample from the pipette stem. Once the sample has been transferred into bottle number 1, the sample diluent, recap the bottle and mix well by inversion. Open the sample diluent and pour the entire contents into the center of the membrane unit well. The sample should be absorbed quickly. Wait for all the liquid from bottle number 1 to be absorbed completely. Resuspend the color developer by slowly inverting. Mix the solution thoroughly until the reagent is evenly suspended. Pour the entire contents of bottle number 2 into the center of the membrane unit. The solution should be absorbed quickly. Wait for the solution to be absorbed completely. Open bottle number 3, the clarifying solution, and pour the entire contents into the center of the membrane unit well. The solution should be absorbed completely. The clarifying solution will reduce the background to provide more contrast to the spots and facilitate reading. Immediately read the result while the membrane is still wet. Do not read the results if more than 5 minutes has elapsed following the addition of clarifying solution. When reading the results, make sure the tab of the membrane unit is orientated towards you. Non-reactive result. One blue control spot that is clearly discernible above any background tint should appear on the membrane. The control spot indicates the test has been performed correctly and a human specimen has been used. Reactive result. 2 blue spots. One control spot and one test spot that are discernible above any background tint indicates that the specimen contains HIV-1 and/or HIV-2 antibodies. Following a reactive test result, HIV confirmation testing should be conducted. Invalid result. The test is invalid if there is no control spot on the membrane. An invalid test result means that the test was run incorrectly or insufficient specimen was added. Invalid test results cannot be interpreted. Any invalid test should be repeated with a fresh specimen using a new membrane unit, kit components, and support materials. The INSTI HIV Rapid Antibody Test Kit is intended for use by personnel in medical facilities, clinical laboratories, emergency care situations, physicians' offices, voluntary counseling and testing programs, and other establishments providing healthcare. For more information, please visit us at www.biolytical.com.
ALEER, knowing now matters. The ALEER determine HIV 1-2 antigen antibody combo test procedure for fingerstick whole blood samples. The ALEER determine HIV 1-2 antigen antibody combo is an immunochromatographic test for the simultaneous and separate qualitative detection of free non-immunocomplexed HIV-1 P24 antigen and antibodies to HIV-1 and HIV-2 in human blood. Any modification by the laboratory to the ALEER determine HIV 1-2 antigen antibody combo test or the FDA-approved ALEER determine HIV 1-2 antigen antibody combo test instructions will result in the test no longer meeting the requirements for waived category. A CLIA certificate of waiver is required to perform the test in a waived setting. Additional CLIA waiver information is available at the Centers for Medicare and Medicaid website at www.cms.hhs.gov/CLIA or from your state health department. Test kit components. Each ALEER determine HIV 1-2 antigen antibody combo kit contains 1 aluminum Ziploc pouch containing either 5 test cards with 25 test units or 10 test cards with 100 test units, a desiccant package, chase buffer, a quick reference guide, package insert, subject information notices, a customer letter, disposable capillary tubes for collection and transfer of fingerstick samples, and disposable workstations. Materials required and available as an accessory to the test kit. ALEER determine HIV 1-2 antigen antibody combo controls. Materials required but not provided. To perform the test with fingerstick whole blood specimen, you will need a timing device, a sterile lancet capable of producing 50 microliters of blood, disposable gloves, sterile gauze, antiseptic wipes, and a biohazard disposal container. Test and sample storage requirements. The test kit and chase buffer must be stored at 2 to 30 degrees Celsius or 36 to 86 degrees Fahrenheit. Whole blood collected by fingerstick should be tested immediately. Test preparation. Open the aluminum pouch containing the ALEER determine HIV 1-2 antigen antibody combo cards. Remove the desired number of test units from the 5 or 10 test unit card by bending and tearing at the perforation. Removal of the test units should start from the right side of the card to preserve the lot number, which appears on the left side of the card. Return the unused test units to the aluminum pouch and close the pouch with a Ziploc. Store the unused cards and test units only in the aluminum pouch containing the desiccant package. Carefully close the Ziploc so that the cards are not exposed to ambient humidity during storage. Remove the protective foil cover from each test unit. Lay the test unit flat in the workstation. The test should be initiated within 2 hours after removing the protective foil cover from each test unit. Do not touch the sample pad with your fingers. Use of the workstation is optional. If the workstation is not used, place the test unit on a flat surface. Fingerstick preparation. Optimize blood flow prior to collection. Warm the hand by washing the hand in warm water or holding it in a heating pad or hand warmer for a couple of minutes. Lower the hand below the heart level before collecting a drop of blood. Massage the finger with a downward motion several times before performing the fingerstick. Test procedure. Collect fingerstick sample using the capillary tube. Caution: the capillary tube must be used to collect the fingerstick sample. Clean the finger of the person being tested with an antiseptic wipe. Allow the finger to dry thoroughly or wipe dry with a sterile gauze pad. Using a sterile lancet capable of producing 50 microliters of blood, puncture the skin just off the center of the finger pad and wipe away the first drop with sterile gauze. To collect an adequate sample volume, quickly express blood down the fingertip by gently squeezing across the entire finger to the last joint, not to the end of the fingertip. Collect the second drop of blood by holding the capillary tube horizontally and touch the tip of the capillary tube to the blood sample. Filling of the capillary is automatic. Do not squeeze the bulb while sampling. Maintain this position until the flow of the sample has reached the fill line and stopped. Adding the fingerstick sample to the sample pad. Touch the tip of the capillary tube containing the blood sample to the sample pad and expel all of the contents by gently squeezing the bulb. When all of the blood is transferred to the sample pad, wait 1 minute to ensure the chase buffer does not overflow the sample pad, and then add 1 drop of chase buffer to the sample pad. Caution: do not lift the capillary tube from the sample pad before all the blood has been transferred. A bubble may form which will prevent the complete transfer of sample. If a sample won't expel, cover the small opening at the mark on the capillary with a gloved finger. Then squeeze the bulb until the sample is fully dispensed onto the sample pad. Only the liquid provided in the chase buffer bottle should be used. Do not use water or other liquids. Read the test result between 20 and 30 minutes after the addition of the chase buffer. Do not read the results after 30 minutes. Discard the used capillary tube, test unit, and any other test material into a biohazard waste container. Interpretation of results. Antibody reactive. 2 lines, control line and antibody line. A pink-red control line appears in the control area, and a pink-red antibody line must appear in the lower test area of the test unit. The intensity of the antibody and control lines may vary. Any visible pink-red color in both the control and lower test areas, regardless of intensity, is considered reactive. A reactive test result means that HIV-1 and/or HIV-2 antibodies have been detected in the specimen. The test result is interpreted as preliminary positive for HIV-1 and/or HIV-2 antibodies. Antigen reactive. 2 lines, control line and antigen line. A pink-red control line appears in the control area, and a pink-red antigen line must appear in the upper test area of the test unit. The intensity of the antigen and control lines may vary. Any visible pink-red color in both the control and upper test areas, regardless of intensity, is considered reactive. A reactive test result means that HIV-1P24 antigen has been detected in the specimen. The test result is interpreted as preliminary positive for HIV-1P24 antigen. A test result that is preliminary positive for HIV-1P24 antigen in the absence of reactivity for HIV-1 or HIV-2 antibodies may indicate an acute HIV-1 infection in the test subject. In this case, the acute HIV-1 infection is distinguished from an established HIV-1 infection in which antibodies to HIV-1 are present. Antibody and antigen reactive. 3 lines, control, antibody, and antigen line. A pink-red control line appears in the control area, and a pink-red antibody line must appear in the lower test area, and a pink-red antigen line appears in the upper test area of the test unit. The intensity of the antibody, antigen, and control lines may vary. Any visible pink-red color in the control area, the lower test area, and the upper test area, regardless of intensity, is considered reactive. The test result is interpreted as preliminary positive for HIV-1 and/or HIV-2 antibodies and HIV-1P24 antigen. Non-reactive result. 1 line, control line. A pink-red control line appears in the control area of the test unit, and no pink-red antibody or antigen line appears in the lower test area and the upper test area of the test unit, respectively. A non-reactive test result means that HIV-1 or HIV-2 antibodies and HIV-1p24 antigen were not detected in the specimen. Invalid result, no control line. If there is no pink-red control line in the control area of the test unit, even if a pink-red line appears in the lower test area or the upper test area of the test unit, the result is invalid and the test should be repeated. If the problem persists, contact Alere technical support. The Alere Determine HIV-1-2 Antigen Antibody Combo Test Kit, detecting HIV earlier at the point of care than ever before. The first and only FDA-approved rapid point-of-care test that detects both HIV-1 and HIV-2 antibodies, as well as free HIV-1p24 antigen. A fourth-generation rapid test with the ability to identify HIV earlier than second- and third-generation antibody-only tests. This enables healthcare providers to diagnose HIV infection earlier, allowing individuals to seek medical care sooner. For more information, please visit alerehiv.com/US.
Now, introducing the latest in advanced HIV testing, OraQuick Advance. OraQuick Advance offers the only FDA-approved rapid HIV-1 and HIV-2 antibody test for oral fluid, fingerstick whole blood, venipuncture whole blood, and plasma samples. Now, testing for HIV-1 and HIV-2 antibodies can be administered with the ease and convenience of oral fluid, and the results are greater than 99% accurate. It's fast, simple, with results in 20 minutes. OraQuick Advance. Results right here, right now. The OraQuick Advance Rapid HIV-1-2 Antibody Test allows you to take action now because its breakthrough technology is easy to use and extremely accurate. This test involves just a few hands-on steps, and the results are read directly from the device. You don't need any special lab equipment to perform the test or read the results. The assay is read visually and is meant to be used as a point-of-care test to aid in the diagnosis of HIV-1 and HIV-2. OraQuick Advance is a qualitative in vitro immunoassay that detects HIV-1 and HIV-2 antibodies in oral fluid, plasma, fingerstick, and venipuncture whole blood specimens. This demonstration is focused on providing step-by-step instructions on how to perform the test for oral fluid and fingerstick whole blood. Venipuncture whole blood and plasma samples may also be used with the OraQuick Advanced Rapid HIV-1 and 2 antibody test by using standard phlebotomy procedure and collecting a whole blood sample. Venipuncture whole blood may be collected in any of the following anticoagulant test tubes: EDTA, sodium heparin, sodium citrate, and ACD solution A. Plasma may be collected in an EDTA test tube only. For more detailed instructions on use with a venipuncture whole blood and plasma, please refer to the OraQuick Advanced Package insert. With each case of test kits, you will receive the following items: a customer letter, product insert, subject information pamphlets, reusable test stand, collection loops for use with plasma, fingerstick, and venipuncture whole blood samples, pouched assays including a developer solution vial, and a test device. Each test device has a porous flat pad, which is placed into the developer vial, and a test strip that can be seen through the result window. Kit controls for the OraQuick Advanced test are also available separately. They consist of 3 vials, an HIV-1 positive control, an HIV-2 positive control, a negative control, and a product insert. The kit control should be stored at 2 to 8 degrees Celsius, which is 35 to 46 degrees Fahrenheit. Kit controls are run under the following circumstances: each new operator prior to performing testing on patient specimens, when opening a new test kit lot, whenever a new shipment of test kits is received, if the temperature of the test kit storage area falls outside of 2 to 27 degrees Celsius, which is 35 to 80 degrees Fahrenheit. If the temperature of the testing area falls outside of 15 to 37 degrees Celsius, 59 to 99 degrees Fahrenheit, and at periodic intervals as dictated by the user facility. The following items are required but are not included as part of your test kit: a timer, a clean disposable absorbent workspace cover, and a biohazard waste container. Additional items required for fingerstick and venipuncture whole blood collection and plasma specimens include latex, vinyl, or nitrile disposable gloves, antiseptic wipes, sterile lancet or standard phlebotomy materials, sterile gauze pads, and centrifuge to process plasma specimens. Make sure you have received training on how to safely handle potentially infectious blood and body fluids before performing the fingerstick or venipuncture collection procedure on a patient. Oral fluid is not necessarily potentially infectious unless it contains blood. Use of gloves for oral fluid is optional. Test administrators with breaks in the skin, cuts, abrasions, or dermatitis should wear gloves when performing oral fluid testing. Wash hands thoroughly after performing each oral fluid test and after contact with oral fluid. Prior to beginning the testing procedure, provide the patient with the included subject information pamphlet that contains important information about HIV/AIDS and the OraQuick Advanced Rapid HIV 1-2 antibody test. This test may be stored between 2 and 27 degrees Celsius, which is 35 to 80 degrees Fahrenheit. However, you should allow the test kit to come to operating temperature, 15 to 37 degrees Celsius, 59 to 99 degrees Fahrenheit, before it is used. Make sure there is adequate lighting where the test is being conducted. Set the reusable test stand on a flat level surface, covered with a clean disposable absorbent workspace cover. Tear open the 2 chambers of the divided foil patch containing the test device and developer solution vial. Remove the vial. To prevent contamination, leave the test device in the pouch until you are ready to use it. Carefully uncap the vial by gently rocking the cap back and forth while pulling it off. Set the cap on your workspace cover. Slide the uncapped vial into the stand. Be sure not to force the vial into the stand, as splashing may occur. Have the person being tested remove the test device from the pouch by the handle, making sure the flat pad is not touched. Check to see that an absorbent packet is present. If no absorbent packet is present, discard the device and obtain a new pouch for testing. Direct the person to place the flat pad above the teeth against the outer gum. The person should swab completely around the outer gums, both upper and lower. Both sides of the flat pad may be used. Do not allow the person to swab the roof of their mouth, inside of cheek, or the tongue. Instruct the person being tested to insert the flat pad of the device into the vial, making sure the device reaches all the way to the bottom of the vial. The device must remain in the vial for the duration of the test. Pink fluid will appear and travel up the result window, and will eventually disappear. Results may be read after 20 minutes, but not after more than 40 minutes. The following demonstration will demonstrate proper use of OraQuick Advance with a fingerstick whole blood sample. The first step is to cleanse the patient's middle or fourth ring finger with an antiseptic alcohol wipe. Let it completely air dry, or wipe it dry with a clean gauze pad or cotton ball. In the area just off center of the finger pad, use a sterile lancet to puncture the finger. Discard the used lancet in the sharps container. Gently express a small amount of blood. Wipe away the first drop of blood and express another droplet. Avoid excessive squeezing of the finger to make it bleed. Touch the round end of the specimen collection loop to the blood droplet. Inspect the collection loop to be sure the blood specimen is completely contained within the loop. Immerse the blood-filled collection loop without touching the sides of the vial all the way into the developer solution vial and stir gently. The solution should look pink if the sample was added correctly. Discard the used collection loop in a biohazard waste container. Remove the test device from the foil pouch. Check to see that an absorbent packet is present. If no absorbent packet is present, discard the device and obtain a new pouch for testing. Do not touch the flat pad of the device. Do not cover the 2 holes in the back of the device with labels or any other materials. Doing so may cause an invalid result. Insert the end with a flat porous pad all the way down into the developer solution vial. Make sure the flat pad touches the bottom of the vial. Be sure that the result window faces forward so it can be easily read. Start timing the test. Do not remove the test device from the vial until you have first read the test results. Read the test results after 20 minutes, but do not wait more than 40 minutes. The procedure for reading results is the same for all specimen types. If a single reddish-purple line only appears on the test strip next to the triangle labeled C, the result is non-reactive. This means that no antibodies to HIV-1 or HIV-2 have been detected in the sample, and the result is interpreted as negative. If a reddish-purple line appears next to the triangle labeled C, and a reddish-purple line appears next to the triangle labeled T, the result is reactive, which suggests the presence of HIV-1 and or HIV-2 antibodies. Even if one of the lines appears darker than the other, it is still considered a reactive result. A reactive result means that antibodies to HIV-1 and or HIV-2 have been detected in the sample, and the result is interpreted as preliminary positive for HIV-1 and or HIV-2 antibodies. A preliminary positive result should be confirmed with an additional test before a patient can be conclusively diagnosed as HIV positive. People whose tests show either a negative or a preliminary positive result with the OraQuick Advanced Rapid HIV-1/2 antibody test need to receive counseling to help them understand what the result means to them. Proper counseling procedures should be administered. A test is invalid if no reddish-purple line appears next to the C triangle, if any of the lines are not inside the C or T triangle areas, or if a red background in the result window makes it difficult to read the results after 20 minutes. An invalid test result means that there was a problem running the test, either related to the specimen or to the device. An invalid result cannot be interpreted. An invalid test should be repeated with a new test device, developer solution vial, and a new specimen, either an oral fluid, plasma, fingerstick, or venipuncture whole blood sample. It is important to bear in mind that the OraQuick Advanced Rapid HIV-1/2 antibody test, like any test, has specific limitations. These include: the test must be used according to the instructions in the package insert, and is summarized in this program to obtain an accurate result. Reading the results earlier than 20 minutes or later than 40 minutes may lead to incorrect results. The test has been approved by the Food and Drug Administration for use with oral fluid, fingerstick, and venipuncture whole blood and plasma specimens only. Use of other types of specimens may not yield accurate results. Individuals infected with HIV-1 or HIV-2 who are receiving highly active antiretroviral therapy, HAART, may produce false negative results. Clinical data has not been collected to demonstrate the performance of the test in persons under 12 years of age. A reactive result using the test suggests the presence of HIV-1 and or HIV-2 antibodies in the specimen. The test is intended as an aid in the diagnosis of infection with HIV-1 and or HIV-2. AIDS and AIDS-related conditions are clinical syndromes, and their diagnoses can only be established clinically. For a reactive result, the intensity of the line in the T-zone does not necessarily correlate with the level of HIV-1 and or HIV-2 antibodies in the specimen. A non-reactive result does not necessarily rule out the possibility of exposure to HIV or infection with HIV. An antibody response to recent exposure may take several months to reach detectable levels. With OraQuick Advance, you'll be providing your patients with the highest standard of care. Now, testing for HIV-1 and HIV-2 antibodies can be administered with the ease and convenience of oral fluid. and the results are greater than 99% accurate. It's fast, simple, with results in 20 minutes. OraQuick Advance. Results right here, right now.
Now we are going to discuss the 2 forms that are required to be completed when testing clients for HIV. You should have a solid understanding of the content of these forms so that when you're meeting with your clients, you can summarize the content in such a way that they can understand. But you will want to give them the opportunity to read these forms themselves and consider it before they go ahead and sign it. The HIV information form should be read and signed by the client before the test is administered. As the name suggests, this form covers basic information about the HIV test and what will happen if the test is positive. This form is the evaluation web, or Luther form. It is required to be completed by any tester that receives supplies from HIV prevention. This form covers client information such as demographics, the reactivity of their HIV test, and assesses their risks and knowledge of PrEP. Now, these forms do take time to complete, so it is important to consider when to do the test, and that is usually determined by what test you are giving. An INSTI test can be done in a matter of minutes, and so you may want to complete the test first and then fill out the form. Conversely, if you're doing an OraQuick, which takes approximately 20 minutes, you're going to want to begin the OraQuick and then complete the form so you can work towards getting the test done in a timely fashion. Now, the Luther evaluation database is where you go to enter the information that you had elicited and placed on the Luther form. After testing a patient and completing Luther form, you have 2 weeks to enter that data onto the online database for it to be considered timely. As a DIS, anytime you're meeting with a client, additional STD testing should be offered. That includes chlamydia, gonorrhea, syphilis, and site-specific testing. So for instance, if a patient reports that they have receptive anal sex, you should offer them anal testing. Finally, we have the HIV Outreach Supply website. Through this website, you are able to purchase condoms, phlebotomy supplies, and effectively anything else that a DIS or your agency might need to further facilitate DIS and partner services in your area. If you have any questions, please contact your ISDH specialist to remedy it. Remember, STD prevention is HIV prevention. Thank you for a great course, and good luck.
Thank you so much for taking the time to view today's training. I hope that all of you were able to learn about a lot of great information for Indiana Disease Intervention Specialists to be able to take out into the field. You truly are the heart of STD prevention, and we truly are happy to have you as the boots on the ground, making sure that infections are broken and that clients are well taken care of. As always, if you have any questions about today's training, we always encourage for you to reach out to the Indiana State Department of Health's STD Prevention Program and to contact your assigned STD specialist. Again, thank you so much for your time and good luck in the field.